Ever wondered how a simple cell can transform into a deadly cancer? Or why certain cancers seem impossible to catch early? Today, we're tackling malignant tumors with a fresh, board-focused perspective.
I'm excited to dive in, especially since we'll break down the big questions med students and clinicians face. We'll connect the dots between morphology, molecular biology, and real-world clinical decisions.
Listeners can expect clarity on cancer progression, high-yield genetic drivers, and the latest updates in prevention and therapy. Plus, we'll spotlight must-know exam patterns and review rapid-fire facts you shouldn't miss.
We'll cover the anatomy of tumor growth, classic gene mutations, prevention strategies, and the cutting-edge therapies shaping modern oncology. Let's jump right into the science.
It's wild how malignant tumor questions almost always span those three domains: morphology, molecular biology, and clinical application. It's never just one piece of the puzzle.
Absolutely, and the patterns are striking. Morphology covers invasion, dysplasia, and necrosis. Molecular biology zooms in on oncogenes and tumor suppressors, while clinical pieces like screening and biomarkers tie it all together.
Funny thing is, once you see the links, like how a gene mutation leads to unchecked growth, and then a screening test picks it up, everything clicks for exam prep. It's all about connecting those dots.
That connection really matters in practice, too. If you can recognize the morphologic clues or genetic changes, you're more likely to catch atypical presentations and make better treatment choices.
Let's walk through the progression. From normal tissue to hyperplasia, dysplasia, carcinoma in situ, and finally, invasive carcinoma. That leap across the basement membrane is the big pathologic milestone.
And it's so easy to confuse benign mimics like choristomas or hamartomas with true malignancy. Choristoma is normal tissue in an odd spot. Hamartoma is just a disorganized overgrowth where it belongs.
That reminds me, students often mix up metaplasia with anaplasia. Metaplasia is reversible and adaptive, but anaplasia is the dangerous, undifferentiated state that signals malignancy.
Plus, dysplasia is a classic stromal response to invasion. It's why some tumors feel so hard or fibrotic. Recognizing these features can make a big difference in diagnosis.
Epidemiology is changing fast. The American Cancer Society projects over 2 million new cases and more than 618,000 deaths in 2025, all excluding non-melanoma skin cancers.
Prostate, breast, lung, and colorectal cancers top the charts. But pancreatic cancer is climbing in both incidence and mortality. That's crucial for board exams and real life.
On the prevention side, primary measures like smoking cessation and HPV vaccination are game changers. Secondary prevention screening for cervical, colorectal, and lung cancers is equally vital.
I'd argue that knowing which cancers are preventable or screenable often shapes your approach to risk counseling and early detection. Those details are high yield for exams and patient care alike.
When it comes to carcinogenesis, chemicals, radiation, and infectious agents are always the main suspects. Tobacco smoke tops the list, but don't forget UV radiation and viruses like HPV or EBV.
And predisposing diseases can really boost cancer risk. Think Down syndrome for leukemia, xeroderma pigmentosum for skin cancer, Barrett esophagus for esophageal adenocarcinoma. It's all about DNA repair gone wrong.
I've seen students trip up on the links between chronic inflammation and cancer. Ulcerative colitis leads to colorectal adenocarcinoma. Cirrhosis sets the stage for hepatocellular carcinoma.
Pattern recognition also comes in handy. Cribriform glands, papillary structures, or small blue round cell morphology, these are classic clues that point to specific cancer types.
Let's dig into the hallmarks. Cancer cells are self-sufficient in growth signals, resist suppression, evade death, and have limitless replicative potential. Angiogenesis and invasion are classic, but now immune evasion and genome instability are also key.
That ties directly to gene classes. Proto-oncogenes like RAS and MYC, tumor suppressors like TP53 and RB, DNA repair genes such as BRCA, and apoptosis regulators. These drive the malignant transformation.
Proto-oncogenes become oncogenes with just one altered allele, think RAS or BCR-ABL. Tumor suppressors usually need both alleles knocked out. TP53 is the guardian. RB controls cell cycle transitions. APC stops beta-catenin signaling.
And don't forget cell cycle and apoptosis. Cyclin D, CDK4 push cells through G1, while telomerase helps evade senescence. Tumors dodge immune surveillance with tricks, like reducing MHC or ramping up PD-L1, making checkpoint inhibitors so important.
Cancer Workup today is all about combining histology, immunohistochemistry, and biomarker testing. HER2, EGFR, ALK, BRAF, and PD-L1 are just a few that guide targeted therapy.
That actually reminds me, paraneoplastic syndromes can be sneaky lab clues. Ectopic ACTH causes Cushing syndrome, SIAD-H triggers hyponatremia, and PTH-related peptide leads to hypercalcemia.
It's impressive how treatments now blend local and systemic approaches. Surgery and radiation control the primary site, while cytotoxic and targeted therapies tackle the spread. Immunotherapy is reshaping the landscape, especially with checkpoint inhibitors.
Translocations are another board favorite. Memorize CML with BCR-ABL, Burkitt lymphoma with MYC, and others like follicular lymphoma and Ewing sarcoma. Those classic pairs often pop up on exams.
For a quick review, invasive carcinoma breaches the basement membrane. Carcinoma in situ doesn't. Dysplasia is a stromal reaction. RAS, MI, TP50I trees, RB, APC, and BRCA are core genes. Tobacco, UV, HPV, and H. pylori are key causes.
Modern therapy is all about biomarkers, think HR2 or PD-L1. And don't forget the updated sources, the 2025 Cancer Facts and Figures, NCI biomarker concepts, CDC vaccine studies, and classic Robbins and Cotran.
3 big takeaways. First, cancer is a multi-step, genetically diverse process. Second, environmental exposures and inherited traits shape risk. Third, treatment selection hinges on molecular testing and immune evasion.
If you're prepping for boards or clinical practice, focus on connecting morphology, genetics, and prevention. Next step, review the latest biomarker guidelines and practice rapid differentials. Thanks for joining us!